So anyway, I know it's a quick presentation. It's hard to talk about, 5 years of our work and 30 years of Bob Langer's work in 20 minutes. But I guess if anybody has any questions, I definitely have my scientists here to answer all the questions. You can tell my presentation today was probably a little bit different than yesterday's. But fire away. Here we go. I couldn't hear the end. It was scaffolding stem cells without the what?
Scaffolding and stem cells, but without the cutting of the scar tissue. Cells to bridge scar tissue and scaffolding for structural support, but without.
Oh yeah, so you say to bridge the scar. You're saying.
Yeah, exactly.
Yeah. We haven't really, with our technology, we don't think that's the best use of our technology. I know other people are trying to do that all the time, but we think our.
Would that be in conjunction with the scaffold?
See, the scaffold is the bridge. You know what I mean? So you don't have to create a bridge because the scaffold is the bridge.
But isn't the scaffolding an external bridge, or is it internal?
No, it's an internal. It'll be internal to the cord. Yep. Want to say anything? Yep.
Very, very impressive data. How much of the effect of your scaffold is anti-inflammatory, and the scaffold has to be given immediately after injury, and you're getting tissue preservation, versus a technology that might be applicable to a chronic spinal cord injury, where the inflammation is taking place, a lot of damage to the spinal cord? How do you see this technology moving to chronic, and what do you think is actually happening in these acute injuries?
Absolutely. Hello. Hi, everybody. So I think that's very important to understand that we are focused on the inflammatory damage in acute spinal cord injuries, but obviously in chronic spinal cord injuries, a lot of the inflammation has subsided. It takes about 4 weeks for all the gliosis to really occur. So when you do get to treating a chronic spinal cord injury, we will require the use of cells, just like Bob Langer said, to treat that chronic spinal cord injury and recover functioning. And that's why I think all of the work that's being done on stem cells is particularly important. But you do need a scaffold to seed the cells onto in order to improve the survival of the cells and keep them localized in the injury area. That's what we feel.
I would absolutely agree, yes. This is very important work with scaffolds. And hopefully, those of us working on cell-based therapies will be working with you guys in future.
Yeah, one of the benefits of in vivo, and again, you guys know, I guess we're probably the second or third publicly traded company. As a company, we can bring all the different people together. Most of the research is done in academic institutions where there's few dollars available, and so we can actually bring all those sciences together. We have, I guess, 6 different disciplines of science on our team right now, and most research comes out of maybe 2 or 3 disciplines, and we intend on adding 3 more in the near future. So, we kind of have it from all different angles. And again, yesterday it was kind of interesting to hear a few people say, now you have an engineering problem. And I said, yeah, and that's been our approach, engineering and cellular.
Question? Frank, I'm just curious about your handout that you put out on the tables. Specifically, your cover sheet says 167,000 may be paralyzed, and on the inside cover it says 5.2 million people are living with a spinal cord injury. Yep. Just curious where those numbers came from.
There's an international group that put out the 160. Actually, it came from the Wall Street bankers, to tell you the truth. They did the research, and there's somebody out there that certified 167,000 people are paralyzed a year around the world. And the 5.2 million, I think, came from the Chris Reeves thing. Yeah,
so 167 came from Wall Street?
No, I mean, they did the research, and there's an international spinal cord injury association out there, I guess, with a number of 167,000.
Yeah, I'm curious, what is the source of your neural stem cells?
Yeah, so the neural stem cells that we did research on are adult human neuronal stem cells. They're actually isolated from the human fetal telencephalic brain region. And then a culture process was developed so that you could expand those cells without gene modifications. So going forward, there's a lot of work being done in iPS cells. There's a lot of work being done to understand how we can use autologous cells or how we can develop cells that don't have some of the class antigen expressing molecules that cause immune rejection. So I think what's happening is the fields are aligning as we begin to get biomaterials approved for spinal cord injury, the stem cell research has really progressed. And what we've seen at MIT over the past 5 years, some of the work that's been developed there, and first going from embryonic stem cells to iPS cells, there'll be an alignment where you have a cell type, and even Geron's done some great work, there'll be an alignment where you have an acceptable cell type that doesn't have immune rejection problems that we can seed on our scaffold and treat chronic spinal cord injuries. So I think it's going to be a collaborative effort from everybody in the research field to make that happen.
We have another question back here.
Maybe I missed it in your presentation, but I'm guessing this is an acute treatment for early spinal cord injury. Are you?
Yeah, the first product we have at the FDA right now is for the acute, but
well,
we believe the model that we'll
curious
use.
about the chronic question, especially.
Yeah.
Is there any?
Yeah, and that's what we showed the scaffolding human neural stem cell monkeys before, and that would be the technology that we would expect to work in the chronic population.
Yeah, just to add to that, actually, what was fascinating in the research that was done acutely with human neuronal stem cells, and actually many labs around the world, particularly in Italy, have really done some basic research on this, was that the neural stem cells, when they're applied in the acute setting, mainly have a neurotrophic and anti-inflammatory effect, rather than differentiating in high numbers into new neurons. At least that's what we found. So a lot of them actually don't differentiate, but they have an anti-inflammatory effect, and you see reduced scar formation and some reduced inflammatory cytokine expression and things like that. So what's sort of really interesting was that actually the research in neural stem cells actually led us to the local delivery of methylprednisolone as a product, because we said, well, they're more intelligent than just a bolus injection of drugs. They can secrete different factors. So if we can apply this biomaterial strategies to do controlled release of steroids and neurotrophins and things like that, you can have possibly the same effect that stem cells are having in the acute spinal cord injury. But everybody's convinced that chronic spinal cord injuries will require a cell therapy, and we're convinced that biomaterials will play a big role in that. You're seeing that in many other indications, treatment of diabetic ulcers and things like that. All of these types of technologies that are cell therapy based do use biomaterials as scaffolding. So it's really going to be a combination treatment.
And there's actually companies using that same, you could say, our theory, and even using our patents. We have over 100 patents. We licensed them from MIT and Harvard, but other companies have licensed the same patents for growing bladders and kidneys, say a company called Tengion. And they're basically using the same product. Bob Langer invented the technology with Tony Italia, who's basically the chief scientist at Tengion. And another company's growing same patent, same material, scaffold, same cells for growing heart valves and other tissues around the body. So, we actually get very excited when you see those other companies. Tengion's had bladders in children for 6 years, where they've, grown bladders, out of scaffolds and stem cells, and implanted them in children, and the children are still doing well 6 years later. There were some adverse events early on, of course, with some of the children. But there are children walking around bladders grown by Bob Langer's technology, and we expect that same. As Bob said, you can't grow, kidneys, pancreas, and spinal cord, without our technologies, and he's doing it in other parts of the body. So, again, we're really excited about it. Also working in the spine. It might not be the whole scar, but a portion of the scar. That's what we would expect. And I know that everybody's going to say, wait a minute, that's going to cause more damage. But actually, when you put the scaffold right in there right away, you prevent that damage from occurring. And you'd be shocked at how permeable you could say that wall is, immediate adjacent to our scaffold, how permeable compared to this. When you don't put it in, of course, you get gliosis and you get a really thick scar. But with our scaffold, you don't get that thick scar. You get a real permeable wall. And if that wall is really as permeable as it looks, then those cells in the chronic population should take right to the spinal cord.
So, a lot of the scar, the scar is really astrogliosis, right? So it's the surrounding astrocytes become reactive to the injury and wall it off and form a new barrier. And, what we're really saying is the scaffold will be implanted into the lesion. And I know Dr. Young's done some great work on decompression laminectomy where they actually remove a necrotic tissue from the core of the lesion, remove macrophages, and actually see benefit there. But that same approach will be the surgical intervention to implant the scaffold with stem cells, and that's the same thing. It's the same type of technology, same type of approach that's used for spinal cord tumor resection. So the surgical procedures are already validated for that.
It's a very different kind of biology.
Mhm.
So,
Yeah.
if I may
Yep.
ask a couple of questions. It's very exciting work. In the past, many acute neuroprotective strategies, be they scaffolds or drugs or cells or what have you, have failed in the translational step to the clinic because of two key issues. One being not using a clinically relevant injury model in your animals. For example, an acute resection lesion is very different from the majority of human injuries. And then secondly is the timing issue. So anything that is given immediately after the injury in animals is not given immediately after injury in humans. In the stroke field, for example, that's caused many, many drugs to fail. So I'm curious, and in spinal cord injury, if you look at methylprednisolone, for example, it was given much, much earlier in the animal studies than it was in the NASCUS trials, which is a big reason why, ultimately, many people ultimately end up very skeptical. So two questions for you. How are you planning to address the issue of the delay in timing that you're going to see in humans that you didn't have in your monkeys? And also, how do you address this very different injury setting? Are you focusing on penetrating injuries in humans that might be more similar to your acute resection injuries in the monkeys?
Yes, so I think the important thing to understand is that any animal research is a model. So if you do rodent work, that's also a model for various different reasons. It is and it isn't applicable to human spinal cord injury. And the same is true with primate studies. I think somebody said yesterday the challenges of doing primate studies are because they are just like humans. If you do a contusive spinal cord injury, you get bladder retention, you get pressure sores, and you get all the same complications that a spinal cord injury patient has, and so the animal care is extremely challenging. So what we did with the Brown-Séquard syndrome and resecting the maximum amount of spinal cord tissue that we could to cause dysfunction without all of those animal care issues, we think is the best model that you can use in primates, and coupled with rodent work, that's definitely the way to go. So we are pursuing rodent contusion studies, of course, but I do think primate research is very important for spinal cord injury. And obviously there are limitations with any model, and this is the type of spinal cord injury model that's well tolerated in primates. So I think that there are limitations there. But going forward, what you said about the delayed intervention, really what we're seeing in our research is that we see a lot of reduction of gliosis around the injury site, and that actually doesn't really kick off until about 3 days post-injury. You don't really see the upregulation of astrocytes in the immediate phase. So there, the difference between immediate implantation and 8 hours, it may not be as significant as perhaps, as you said, for methylprednisolone and things like that. Even though the upregulation of some of the inflammatory cytokines that methylprednisolone would suppress also don't happen immediately, but many of them do. But I think going forward, what's also important to understand is that with our neurosurgeons, and I think the whole field needs to understand that we also do need to change the paradigm of spinal cord injury care. I mean, if we can get somebody in the operating room faster, and maybe you can treat them more quickly. I mean, we had people yesterday saying that their son or daughter came into the emergency room and then waited a week before they underwent decompression laminectomy. I mean, that shouldn't happen. And if there is an acute therapy that is effective, the whole medical field also has to work to make that treatment happen as fast as possible. If that's when it needs to be delivered, I think we can all do more to make that happen.
And by the way, those questions we get every day, all day, and we're answering them all the time. So if we didn't have, we think, the solid answer for them, we certainly wouldn't be proceeding as we are. We would have done something a little bit different. We basically built our company to take corrective action. We don't really care so much about having the perfect plan. We care about responding to changes and modifying things quickly. So we get that question all the time. And our neurosurgeons, again, we're relying on these Harvard neurosurgeons that are probably some of the best and work with spinal cord injury all the time. And they're convincing us that it's solid. So.
Yeah, and just to add to that, we are doing rodent contusion studies with delayed intervention for the injection of the hydrogel, and I think that's very important research, and that's still being completed.
Yeah, and by the way, we just literally, I probably didn't mention, but we made it this far in 5 years on $6.2 million. A couple of primate studies, rodent studies, built out our team. And now we just, closed a big round last week to go public, which in the end will probably be about a $31 million round when it's done. So we're finally actually going to have cash, which is quite amazing. We're actually, we have ideas now, and we can go hire somebody to do it, So we're really excited about it.
Can I ask, as well as tracking ambulation as an outcome measure, are you able to also track the progress of body function? I mean, return of bladder and bowel. I mean, how does that work? How are you
Yeah,
able
so of
to
course,
watch
if you
that?
can, spare that tissue, and of course, the research will say 10% or more. By the way, we have, in comparing our treatments to our controls, we have a 56% improvement in scarring, in the treatments. So, or reduction of scarring, sorry. So if you can spare that tissue, we of course, that lower tissue with acute injury is just waiting to be used. It's already healthy. The great thing about the cord, it's very well vascularized, gets a lot of blood, nutrients, and oxygen. So the tissue below is for many, many years. And, it's just waiting to be used, you could say, if you can just kind of spare that or bridge that. So that's basically it. We bridge it, we spare it, neuroplasticity occurs. See, so our first product has nothing to do with regeneration, nothing. It's neuroprotection, we spare the tissue from dying, and the neuroplasticity, we basically let the spinal cord itself kind of find the new paths and reconnect.
And just to add to that, in our research model in primates, we're doing a thoracic spinal cord injury and actually attempting to avoid bowel and bladder dysfunction. I think going forward, into humans, obviously each injury is distinct. The white versus gray matter is distinct, the level's distinct. So, the type of dysfunction that the patient is observing will, of course, depend on the injury. So it'll be slightly different.
Hello. Thanks very much for that. I think I missed the part where you were talking about the regulatory process. Could you maybe get us up to date on where you are with the FDA?
Was that? Can you repeat that? Sorry.
I was wondering where you are with respect to the FDA and the regulatory process.
Yeah, well, we expect to submit the final IDE. We'll have it ready to go last week of December, and we expect to submit it in early January. And then we hear back in 60 days and go from there. So, I mean, they've given us the roadmap. We've already met with them. They told us what to do, and we're going to go deliver it to them.
Hi, I suppose this is a transaction model, right? And how much of the cord was cut?
It's actually a hemisection. Transection is, hemisection is much more severe.
So the model, I guess we have the slide. So the model is a hemisection model because what we're actually doing is we're removing all of the tissue on one side of the cord, below the T9 nerve root, and above the T10 nerve root. And the goal of it, actually, it was Dr. Tang, one of our early researchers, and did the fantastic work in 2002. Actually, his theory for that was that you would minimize the amount of local reorganization that you can have with a simple transection, where if you just cut the tissue, you can have more reorganization just around that cut. So we felt that was really the most aggressive model that we could do in primates and actually get away with before you'd see bowel and bladder dysfunction.
Would you do it on complete severed cord?
So we think it's more meaningful to actually remove a distance of spinal cord than necessarily cut the entire cord. And the purpose for that is if you're looking at neuroprotection, you do need to have some spinal cord tissue left over to see whether you do get neuroplasticity and do get recovery. And also, the amount of dysfunction that you expect after doing the surgical hemisection is that only the left leg is paralyzed and the right leg remains functioning. And therefore, then you can nicely measure, what the dysfunction is in the left leg. And if it's returning, that there's some plasticity occurring that's enabling that.
Is it necessary to compare with contusion model?
Absolutely, and like everybody said, is actually Dr. Young's developing a contusion impactor for primates, and it'll be certainly interesting to see how you can manage the animal care with that. But maybe it's possible we do it in humans. With enough funding, you could probably do a contusion injury in primates. What's more important is with the appropriate people who can do the animal care. That's actually the real challenge.
So more collaboration.
It's less a funding issue. It's really, can you get enough staff to care for a paraplegic primate with bladder retention? Of course, they're a bit less docile than a human, so they're a little harder to take care of when you need to express their bladders and things like that. But I think comparison with contusion models in rodents is very important, and so we're pursuing that. And actually, we were down with Dr. Young back in June and learning everything about his contusion model, and we've done contusion research in the past with Dr. Tang and things like that. So going forward, it's really going to be both. Contusion models in rodents with delayed intervention is absolutely the gold standard. Absolutely. For rodents. And then in primates, we think we're developing the most aggressive primate injury model. And there are a few others that Dr. Edgerton has worked on in primates too, where they just cut the corticospinal tract. But again, that's quite a different
Thank you.
story.
Great
Sure.
invention. Thank you.
And one of the things that really, it didn't really, I guess, surprise us, but to really see it, was just how the monkeys looked just like humans and suffered, you know, in a way. Well, by the way, didn't have any pain at all. With the way we paralyzed them, we don't have pain. They took painkillers for 48 hours, and that was it. And that was just for the incision, you know. But basically, they responded and needed the care just like a human. Very intensive care, bladder control, bowel control, all these different kind of care. And, you know, of course, one of the things we got pushed back on early was why I selected human doctors to do primate work. And of course, I told you, our mission is to get the humans. So how about using some human doctors, right? People said, no, you should have vets and they're experts and all that. But we chose to go with the human doctors. And when they sat back and they said, boy, these monkeys are exactly like humans. You know, they really were behaving and experiencing an injury just like a human subject would.
I have 2 questions, and I think you already answered the one. When are you planning to do study on chronic patients? I think I just missed that. If you could answer that.
It'd probably be a few years away, we think. But again, see, we're concurrently engineering our technology. We've had 5 different treatment arms show therapeutic effect in monkeys. 5 different treatment arms show therapeutic effect. So
okay,
we have them all going at the same time, but most likely a human study probably wouldn't start and chronic probably wouldn't start for a few years.
Okay, the second part of my question is, you were saying that his father is a quadriplegic?
His father had a spinal cord injury, actually. Oh, no, that was, well, Rich Roberts' son was a quadriplegic, maybe that's what I said.
Are you willing to use him in your study? Are
Well,
you
he
confident
unfortunately,
enough?
he has multiple levels of injury, including a serious brain injury. So he probably wouldn't be a good subject early on.
Okay.
One right over here.
Thank you. I was curious because with Brown's acquired, you have both motor problems and then sensory problems on the other side. Are you examining the sensory recovery as well as the motor recovery?
Yeah, that's a tough one. And actually, you know, for the past couple of years, we've been debating, you know, what the best way to assess that is. And obviously, there are some techniques like heat pad and things like that you can use. Difficult to apply in primates. You know that.
Yeah, we've had multiple meetings this week to discuss our sensory testing for our next study.
We are working on it. We have a couple of ideas surrounding the use of lasers. It has to be things where you can probe the subject without the risk of getting bitten, to be honest, or attacked.
Animals are dangerous.
So they are extremely dangerous, and so you know, the use of lasers or remote probing of sensation is very important. And we you know, obviously that's one of the most important things to address. You know, locomotor function is not the only thing, but you know, what we're looking at is a correlation between the underlying biology, like was previously said, and some functional outcome, which is the EMG recordings, and you know, a kinematic outcome, which is movement. So if we can correlate, you know, what we're seeing in the tissue with the recovery of function, even if it's locomotor function, that says something about the plasticity that's occurring. You know, and if you saw return of sensory function, that would tell you the vice versa. So we've thought about somatosensory evoked potentials, just like we're doing EMG. Thought about using lasers, and we're actually working to incorporate those things now. But yeah, that's a great point.
I think we were supposed to end at 9:30, right? Oh, okay, got it. Okay. Geez, I would have spoke longer. But anyway, yeah, we've been at it a while, and again, we're building out our team now. We're looking for additional scientists and disciplines in medicine to join our team, and really looking forward to the future. Somebody have a question? Or?
Another question over here.
This is similar to the question I was asking Dr. Davis yesterday. You guys, since you guys are industry, you probably have better data on how much more expensive is you know, a primate study than a rodent study. You know, in terms of cost per animal, maybe?
I would say that it's not that much. It hasn't been much more for us. You know, we leave the U.S. and cut costs that way. But, you know, I can tell you I've received proposals for rodent studies, like 48 rats, that are larger than our 18 primate study, 18 animal primate study.
So, I mean, how many caretakers do you have full-time?
Well, that's the great thing. We're down in the Caribbean. They get paid, a few dollars an hour, really. So we have a lot. They're 24-hour care. And by the way, we've learned as we've gone. Again, we had no roadmap to follow. So what are the animals going to look like on day 1, 2, 3, and 4? And we of course record all that. And then in the next studies, enhanced animal care. I mean, we didn't have to do anything to our device or technology or anything. We had to really focus on animal care and as far as improving upon the next studies. So they have a lot of people down there. And by the way, they're great. The research center is part of Yale Medical School. It's NIH funded for about 25 years. Some of the people have been at this center for 30 years, the employees. And, they don't really have a lot of options, right? They're on an island in the Caribbean, so they're,
right. And so with the hemisection injury, the animals have voluntary bowel and bladder, and they have no issues with pressure sores. Is that correct?
That's right. That's right. As long as the injury remains a hemisection, there's no ventral arterial damage. That's correct. Yep. But if there is some unexpected damage to the blood supply in the spinal cord, yeah, you get a spinal cord infarct, and you have the same kind of care complications in a human patient. And they get pressure sores, they get bladder retention.
So you guys don't have any current plans to, impose a more severe injury on the animals?
I really don't think necessarily that's the important point about doing primate research. A lot of what was really discussed in some of the literature and some of the people we work with, Dr. Cortina in particular, in Zurich on primate research, is the anatomy of the cord and the number of spinal cord tracts that's in a primate spinal cord. I mean, we were talking yesterday about astrocytes, and the density of astrocytes in an African green monkey as compared to a rodent is just phenomenal. If you look at the tissue, I mean, I can send you some pictures. It's a completely different picture. So I think the important thing is that the animal model, in terms of its underlying anatomy, is very similar to humans. I think it would be nice to do a contusion spinal cord injury, but I think the more important point is to do a severe injury with manageable animal care. Otherwise, you get nowhere. Your study gets shut down, and we can't do anything. What we have had a lot of conversations about, especially now with some additional funding, is the creation of a chronic primate. And Rich Roberts in particular is the one who's actually yelled at us for the last 5 years that why haven't we already done that? And that's actually, that would be the next step, is a chronic primate model.
I'll tell you.
And if you do the Brown-Séquard syndrome, you can manage. They won't have those. They won't have the care issues, bladder care issues, and it would be feasible to create a chronic primate spinal cord injury model.
Thanks, guys.
Did I hear you say that you're going to do 10 human acute patients?
Well, the FDA has pretty much come back with what they've come back for every other study. Geron and everybody's 10 people, kind of take it one at a time, so we go from there.
So how long would that take? Who knows? You're just going to do one and then wait and see what happens?
They actually use a number 2. I know Geron got into 1. We're very different technology than Geron, so I guess we'll have to see. We're hoping, we have really about 6 months most for enrollment. So the 2 centers we're going to do our work in, one's in Boston, where we get 1 paralyzed patient a week, and one's in Washington, and they get about 4 a week in that hospital. So we don't think it'll take that long. And we're actually expanding now to additional facilities probably. We're probably going to add 1 more to the first study. So we'll have 3 facilities in the first study.
It seemed like that you got your monkeys out of bed and working on walking at day 2. Are you also assuming that your human subjects will be up and have activity that quickly?
I think it's important to understand that the difference between an animal model, whether it's a rodent and a primate, and a human spinal cord injury, and the answer is, it really depends on what the human spinal cord injury is. And as you know, there are some people who have spinal cord injuries, and we have someone who works for us who had a cervical contusion, and if you look at his MRI, there's barely any of his spinal cord yet left, and he can pretty much walk with the use of crutches. Very different story from Andy Roberts, and he suffers a lot of dysreflexia, but in terms of locomotor function, he can pretty much walk. So I think it's important to understand the difference between trying to address the underlying pathology of spinal cord injury and what's happening, what happens at the time of accident to the person's body, and what happens during that secondary injury phase, and what evolves in the chronic phase, and what the reality would be for each spinal cord injury patient. So the short answer is that what we'd just love to achieve is an incremental improvement in functioning for a human spinal cord injury patient. I mean, if you could take someone off a ventilator that would otherwise be on a ventilator or recover a little bit more functioning than they have, I mean, that's a huge success for spinal cord injury. So yeah, I think that's important to understand. And as you know, it's not always about walking. There's so many other issues. But what you're looking for at that level, at the point of the spinal cord injury, is to reduce the damage and improve survival of tissue and health of tissue.
One thing we didn't mention is the device is biodegradable, so we basically can program it to dissolve into the blood system once it's done its job. So in the first study, we had a program that lasted about 6 weeks, and it was like 99% gone in 6 weeks. And in the second study, at the 12-week mark, it was completely gone. So we're going to see therapeutic effect, we believe, in the first month, you know what I mean, first 4 to 6 weeks. So, you know, as opposed to other studies where you might have to follow people a real long time, you know, somebody would probably have to have another injury or something to kind of go backwards. So we think once we defeat that secondary injury, you know, the device is no longer needed, so it dissolves into the blood system. And that's why there's only a 1-year follow-up. The FDA literally said, what are we going to follow? It's gone, you know? So
I'm curious then, at 6 weeks, what sort of tissue do you have in the spinal cord? What are you seeing if this material's degrading away? What's the main component of the tissue that's left, or what forms?
So really, as you know, even in a contusion injury, the lesion's a necrotic cavity and it's filled with macrophages, and it's somewhat similar. And I mean, when you have the scaffold there, you actually get less macrophage invasion, which is natural. And like Frank showed, you do get a little bit of gliosis around the side of the spinal cord injury, but you know, it's not like there is some ingrowth of neural tissue, and we showed that in the 2002 paper, that as many groups have shown, there's some axon ingrowth into the lesion and things like that, but it's not like a new spinal cord grows, and that's precisely why cell therapies are so important. You know, I don't know whether you could do anything even with you know, very controlled delivery of neurotrophins and steroids and all the combinations that we could come up with, that we can do with biomaterials technology, whether you could coax the body to regenerate like the salamander that was shown yesterday. I think cell therapy is a key for chronic spinal cord injury.
Yeah, it's quite possible in the future our device will time release drugs the first 7 to 10 days, and then time release stem cells after that. That's kind of what we envision down the road, probably about 10 years from now, where you'll kind of have the intelligent device, you could say, to release whatever required at that time to defeat secondary injury.
So I've been asking some very tough questions here, but I'm a big fan of this type of scaffold work, and I think it's vitally important that these sort of scaffolds are provided, are available, FDA approved, and obviously to work in combination with other therapies. So it's really great work you guys are doing.
Thank you.
Thank you.
Yeah, and again, we're looking for great, talented people, so new disciplines, and you know, now we got money. So.
Okay. Can you say a few words on your strategy for controlling your later studies after you've demonstrated tolerability?
Yeah, that's a great question. God, I had probably about 5 meetings in the last month on that one. And so what we're doing is we've, you know, the model system has their 16-page kind of survey that tracks the patients after injury. We've looked at that survey and added about 4 pages of questions to that. And we're actually exploring 2 options. We want to explore using that database as a control group where we can identify patients. You know, there is going to be a lag to that, though, of course, because you have to get into the system. So we'll probably find out later on or whatever. But, you know, people injured at the same time, the same type of injury, and we get all their data in the model system, and we're hoping to kind of use that as a historical control. We certainly don't want to, you know, obviously we can just take control patients too, right? There'll be people having spinal cord injuries all over the U.S., and hopefully if we can get them in a similar rehabilitation program as ours, if not ours, right? You know, we can compare them to the controls, people having real injuries. But there's a lot of data in that model system, so we kind of like that data. There's a lot of information in there.
I mean, just from a humanitarian standpoint, you know, you obviously have to have a randomized control study, but that's sort of sad in a way, right? Because if the treatment, you know, did work, and if you've already proved safety and no adverse effects in your pilot study, it'd be a shame to have 10 people or 30 people in a control study that weren't receiving any benefit. Yeah. But so what we think is, you know, this database has many more patients in it, and much more understanding of, you know, the transition from Asia A to Asia B, and what types of functioning is recovered after different spinal cord injuries. That may be a more appropriate control with a larger sample size when you're obviously already limited with the sample size in your treated patients, why limit the control group? So I think, you know, maybe the FDA will accept both. I mean, both is better, right?
Yeah, we definitely want more information. Okay, so we're all set, I guess. Okay.
Visit u2fp.org for more coverage from Working to Walk and the latest in spinal cord injury news.